This podcast represents my opinion and the opinion of my guests. This is not medical advice, and I am not establishing a patient-physician relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only. And because each patient is so unique, please consult your healthcare professional for any medical questions you may have.
Welcome back, everyone, to another episode of the Not Your Doc podcast. I'm your host, Vanessa, and once again, we're still on baby watch, so I am not with Seth and Dr. Tadros in the Midwest Hearts and Minds studios, but I wanted to pop in and say hey and introduce the second part of the discussion with General Surgeon Dr. Michael Smith. This week's topic is on that ever-problematic vestigial organ we're all carrying around, and that's the appendix. There are 250,000 cases of appendicitis annually in the U.S., and almost all of them require surgery. 10% of Americans will get appendicitis, and it tends to occur in two peak populations, as the doctors will go on to discuss. The majority of cases occur in the young, between 10 and 20 years old, and then the next peak is in older folks, ages 60 and up. I had appendicitis myself at 18 years old, and several of my friends did around then as well. So this certainly tracks with my experience. It seems you either got your wisdom teeth taken out surgically or your appendix in high school, and that's pretty much how it happened. So now I'll kick it back to Mr. Not Your Doc himself and Dr. Smith. Take it away, Dr. Tadros.
This is Chuck Tadros. We're back again with Dr. Michael Smith. Dr. Smith, general surgeon, recently retired, was in private practice 1991 till December of 2021. Has been a general surgeon up in Iowa and here in St. Louis, Missouri. Has had extensive experience, not just general surgery, but also cancer committees and critical care committees and infection control committees, et cetera. It goes on and on. He's got yards, wads, and gobs. That's a term my old physics teacher used to say. Yards, wads, and gobs of experience. And but he's a great guy and a great general surgeon. Welcome back, Mike.
Well, thank you, Chuck. It's nice to be here.
We're going to be talking about appendix and appendicitis. Of course, we were all taught the appendix was a vestigial organ. But tell me, let's start at the beginning because, you know, we have probably a broad range of people who are listening with backgrounds, a variety of backgrounds. Can you tell me just about why we have an appendix and maybe other animals, and what's the purpose of the appendix?
Well, that's a good question. I don't think anybody's really nailed down exactly what it does.
Sure.
I remember reading something a long time ago that they thought it may have been some vestigial organ helped to when we were more animal-like, that we'd eat meat off the bone and have bones fragments that would help to dissolve the bones. But there's been no actual function of the appendix that we know of in the modern day.
Well, more recently, it's a good point. It's not anatomical the way that you're thinking, but more because I'm an internist by training.
Vestigial.
It's vestigial. Yeah, more is that we now know that it seems to house bacteria. So whenever we wipe out a bacteria with antibiotics, we get a small intestinal bacterial overgrowth, or we get actually whenever we wipe it out for C. diff, when we treat it, that we can repopulate it. It seems to come from something like the appendix. It seems like you could repopulate the colon more easily.
That's one of those things that's very hard to try and diagnose or make that association, because while people get colonoscopies and you can see the appendiceal orifice,
yes,
the rule is you don't put something inside there because you may perforate it.
Right. Yep.
And so that's why people don't do that. Now, having said that, there is a large, like you said, a large number of people who think that that's where a lot of this stuff, as far as bowel repopulation, occurs.
Yeah.
And that's where some of the oral agents that you can give, because their liquid will go into the appendix and help to repopulate more quickly and stuff like that. It's also, I read a couple of things a long time ago that talked about there's still a fairly high clostridial count in the appendix, and that may be where C. difficile also has origins.
Yeah, interesting. I had not seen
so that and higher than, if you will, normal anaerobics, along with diverticulosis, could lead to some of those things like that, or toxic colitis or things like that.
Yeah.
But the appendix, I guess, is one of those things that most people are familiar with appendicitis.
Yeah,
I'd say
that's right.
what,
That's how we hear about it.
10 to 15% of the population, I think, over the course of a lifetime.
Is
will
it that
have.
high?
Yeah.
Wow,
I mean, we
I
see
did not know.
we see that there's a peak probably in the teens to
Yes.
mid-teens to that age, and then we start to see that there's a secondary peak starting in the 60s
Yes.
on up. That it's just one of those gradual climbs. It's not as it doesn't reach the peak of 10 to 15% like it does with
youngsters.
younger. But it's one of those things that now, especially with the advent of laparoscopic, it's one of those things can be removed in 15 minutes with oftentimes just 2 incisions.
So first of all, it's the size. It's the size. What it's about. It's about.
Most of them are about the length of your little finger and maybe about 2/3 the diameter of your little finger.
So it's kind of a pencil-like, pencil-like structure that sticks out at the beginning, where it's the beginning of the colon. People think the colon starts at the rectum, but it's at the beginning of the colon where it starts, where the small intestines attaches in the right lower belly. So if you're standing up and you bring up your right arm to your pelvis, it's usually where it's housed.
It's just about maybe 2 to 3 inches
Yep.
inside where your hip bone is on the front.
Yep, and
On the right side.
right side, very very low inside the pelvis. It's kind of we call it abdominal structure, but it's really practically in the right pelvis. Isn't it?
The other thing that's interesting about that is while sometimes we have as the embryo grows into a fetus and into adulthood, the appendix is just a long hose from the mouth to the anus.
That's right.
And so it's interesting if you look, though, that even in patients, as you develop, your bowel will rotate and turn in different directions, so that
Normally
instead of
it's-
it being a one long line,
Right.
is now kind of a folded loop on itself from the right lower quadrant, goes up under your ribs from the right to the left, and then down, and then the sigmoid colon. Even in people who've had malrotations, who haven't had their bowel rotate, they tend to get right lower quadrant pain. And
Interesting.
I mean, it's like, how does that happen if the appendix is over
Sure.
here on the left side? So it's kind of one of those
Yeah,
interesting facts of why does that happen.
So what Michael's describing with malrotation is that we have certain things as a fetus, when a fetus is growing embryologically as an embryo, and then a fetus, certain things actually move into their final position before the baby's born, well before the baby's born. And some people, the right lower quadrant of their belly, where the appendix should live, is actually the intestines did not move in the right direction, and the appendix is in the left lower quadrant. It's called situs inversus. And it could be incomplete or complete. It could be in your heart, in your lungs, in your heart. It could be a bunch of different places in your body. But this is where Michael is talking about. But you still have the pain in the right lower quadrant, where your right lower belly, where you're supposed to have it, and probably because the vessels are still based out of the right lower
from
belly.
The anatomic vasculature.
Yep. So that's so it's very interesting. But there's another structure that's like an appendix that's in 2% of the population.
Meckel's diverticulum.
Yeah, Meckel's diverticulum. Can you tell me about that? Because sometimes it's mistaken, we miss it, or sometimes it's mistaken for appendicitis.
That if you study anatomy across different animals, you'll see that, like chickens or an egg, the yolk sac is basically the equivalent of where the umbilicus would be.
Okay. Yes.
And in that part of the structure is where, I guess you'd say, the upper portion of the intestines meet the lower portion of the intestines, and for some reason, some of them are actually even attached at the umbilical level.
Yes.
And I mean, it used to be thought that as the body grew, the attachment would pull out and would cause an invagination in that area in some people, because you find a little cord,
little ligament.
Yeah. But there's no scientific basis for that type of thing, but it just occurs, and it's just felt that it's at the foregut meets the hindgut.
It's a 2% rule, right? 2% of the population, 2 inches long, 2 feet from the ileocecal valve.
Right.
So 2% of the population gets this Meckel's. Doesn't mean it's infected. Doesn't mean that it ever causes problems. 2 inches long, which is almost about as long as the appendix is, and about 2 feet from the ileocecal valve, which is where the ileum, the small intestine, finishes in the right lower belly, and then and it's 2 feet from the right lower belly back up into towards that, and that sometimes can get infected and also can cause problems.
It can sometimes have the lining of like your stomach in there, gastric mucosa.
Gastric mucosa. I did not know that.
Acid, and that acid, that part of the bowel is not used to being in that acid environment, and it will actually cause a perforation.
Okay, that's how we get
that's how we
trouble.
see perforated Meckel's diverticulum. Others are because, I mean, I've seen a couple that were 6 or 8 inches long.
Much longer, right?
And that becomes like a blind loop.
Right.
And if we do bowel surgery, we don't want to have extra hanging out beyond the, how should I say, a little cove on that river of, if you understand what I'm saying.
Yeah.
So, or backwater, however you want to look at it from a lake perspective or river. So,
because bacteria can be housed there and fester.
Exactly, and that's like we talked about earlier. The appendix carries that. Usually, that part of the bowel is sterile, so it doesn't have infection. So that can become infected from that. If there's gastric acid being released in there, it can perforate and allow the entire contents of the small bowel to leak out because it'll be the lowest pressure.
Why do people get if appendicitis? Not everybody gets appendicitis. Why do people get appendicitis? What's the theory?
Most people think that if you look, probably about 70% of patients will be found to have what's called a fecal lith, which is
fecal stone.
Right. It's where the liquid stool gets in the appendix, and since it's a blind pouch, it'll start to absorb water from that, and eventually that stone gets big enough that it's too big to get back out through that.
Gotcha.
And it's just very hard, I guess you'd say, like constipated stool, that it blocks the opening, and once it blocks the opening, it has no way to let the mucosa, or the mucus that's secreted from the lining of it out. And eventually the pressure starts building up to where. And that's why occasionally you'll see, especially in younger children, you'll see that they'll start having these symptoms of right lower quadrant pain. It comes on, they start getting sick, they may even get febrile, and about the time you take them to the hospital, it's all gone.
Everything's better.
And their white count is at the upper limits of normal. It hasn't gotten to where that's
bad enough.
They don't have a fever yet, and 2 months later they're having the same thing.
Another problem, same repeat.
So
So fecal lith, so it's kind of a blind area that gets impacted by stool that becomes hardened, and then behind the stool, behind the little balled up stool, is you get bacteria, you get pus. What's microperforation? What's a full what's the definition of microperforation? How does it cause pain? How does all this stuff cause pain?
A microperforation is like taking a balloon that you haven't blown up and sticking a needle hole in it, and you blow it up and you see that it'll just kind of slowly.
You can inflate it, but there's a leak.
It doesn't pop.
Yeah, it doesn't pop.
Okay. Whereas if I overinflate it
rapidly,
it eventually will pop if I don't quit letting the pressure off. So what happens is that the pressure inside gets higher than the venous return pressure, so the blood can't return from the lining of the intestine or the appendix, and the arterial pressure keeps pumping it in there, and it just keeps getting more and more pressure to where it basically creates a situation where there's no blood flow. The lining starts to die, and then it starts to affect through the wall, and that's why from the onset to major symptoms, it takes about 24 hours for that process to occur to where they're at a risk for rupture to 24 hours. Okay?
Yeah, so the arterial pressure down there probably is like 120, 140 millimeters of mercury. The venous pressure is probably 40 millimeters of mercury, or probably less.
Probably, 20? I would say low teens.
Yeah, so very low. And so it doesn't take too much.
I mean,
right. It doesn't take too much swelling, arterial pressure going in without the venous pressure being able to take the blood flow out. That eventually and these appendices can become quite big. Is that right?
Well,
quite swollen.
Once they get, I mean, the normal appendix is
Right.
maybe McDonald's straw type diameter.
Right, yeah.
Whereas an acutely inflamed appendix can be as big as your index finger or even your thumb.
Yeah.
And we've seen some that have been 1.5 inches long. We've seen some that are 8 or 10 inches long.
Yeah, it's amazing.
It's amazing the differences in length.
Right.
And you'd think those that have longer appendixes, especially if they fold on themselves and things, that they may be more likely, but that's not necessarily the case.
So parents, of youngsters, does it happen in the middle of the night? Does it happen during the day? Does it happen after somebody gets hit in the belly? What happens?
Usually, there's not really much of an incidence, at least that I recall, of trauma and causing appendicitis.
Right.
So I think that a lot of them, again, it's the types of things that they eat and things like that. Mm-hmm. And I think in children, obviously, everything's smaller in children, so it can be where we talk about 6 millimeter, 7 millimeter diameter in an adult, that could be a 2 or 3 millimeter.
Yeah.
And if they get, that's where the old term typhlitis, because that was like an inflammatory response to the mucosa, and it basically obliterates the inner lumen, and it becomes thicker at the muscular portion where the appendix attaches to the colon, and that's what they used to call typhlitis. A lot of kids who would get appendicitis, but it would be like a missed appendix, or they got better on its own, and 2 months later they had the same thing, and it keeps going back and forth. And finally they take them to the pediatric surgeon. Oh, let's just take this thing out and it'll be done with.
Right. Is there a role for antibiotics instead of surgery for especially young? Nobody wants to put a kid under for anesthesia, obviously. Well, but is there a role for antibiotics, and is there a role for ultrasound to take a look at these?
I think ultrasound is something that's being used a lot more in children.
Yes, and young,
kind of like we talked about with some of the gallbladder and stuff. There's not as big a use in pediatric emergency rooms, but if you go to like Mercy. Or any of the Mercy hospitals, you'll see that they have not only adult, they have pediatric staff there, and so the equipment is there, so people are using it to try and look at that.
Because we avoid radiation of CAT scans, it's quicker.
We used to. I mean, in my training, the basic thing was it took a long time to get somebody to CAT scan.
Yes.
It took a long time to get the CAT scan.
Yep.
And if it was after 5:30 or 6, it wouldn't be read till the next day. So what's the purpose of getting a scan if clinically? And so we used to operate basically, if it looks like a duck and quacks like a duck, it's a duck until proven otherwise. And in a 7-year-old kid, there's no reason not to take it out. So
that's an important. I had forgotten about that. The old-fashioned, if you probably should operate on about 20. In the old days, you probably had to operate on about 20% normal appendix to make sure you didn't miss. There's this interesting statistical issue that
was always the gold standard. Is before all the testing even into the late 80s. That was where, if you thought it was appendicitis, you're better to take it out and be done with it, because two things. Number one, if they've been sick for 12 to 24 hours, the likelihood of going on to rupture before the crow calls is quite high.
Yeah.
If it's beyond that and you've already got the day started, you're either going to have to bump cases or do something to get into the operating room. So if you see it, do it, and so you keep the schedule going.
So the concept here, I want to tell our audience.
The goal is to do it without rupture.
Right.
And those patients recover quickly.
Right. It's
they
easier.
have very few need any antibiotics after. I mean, a lot of times we wouldn't even give a post-op dose in the younger kids, because you can create a colitis from that. So
in the old days, before we had imaging, rapid imaging, or CAT scans, became the standard eventually for years. But is that you clinically, these people would have tenderness in McBurney's point. The classic would be fevers, loss of appetite, tenderness in the right lower quadrant in the special, and rebound, direct tenderness and rebound tenderness. We could come back and talk about that.
They would walk with a limp.
They would protect
because
their right.
When they straighten their leg out, the
piriformis, the hip flexors,
psoas,
the psoas, not piriformis, psoas. You're right, the psoas muscle.
So it rubs on it, and so you get back pain. It radiates back up towards your ribs.
So the psoas muscle, part of the iliopsoas complex, was part of the hip flexors. So these people would kind of stay in bed, and they would lay on their side, and they would bring their knees up to their chest because they couldn't stretch out their hip.
The extensors, actually.
Hip extensors.
It stretched the muscle. And
Bingo. Thank you. So it hurt like the dickens. So they had a certain body position, and they would hold still. They couldn't rock back, unlike a kidney stone person or gallbladder, where they'd rock back and forth and try to pace. These people would hold perfectly still because they had peritonitis. So they had a kind of a classic set. And one of the biggest things whenever I was a young resident and stuff, it was that they lost their appetite. Some people lose their appetite very early, the very first thing. So they lose their appetite. So you weren't sure if they had a virus or anything, because there'd be a kid. They lose their appetite. They have some belly pain. And the belly pain sometimes would be generalized around the belly button, but then it eventually would localize to the right lower belly. And that's when it was like, oh, we thought it was a bug or something they ate. Now it's like, no, now it looks like appendicitis.
That's why they frequently come in after dark. Midnight, because they couldn't get to sleep because it hurt too much, and every time they rolled over, they were crying. And it's like 10 o'clock, and we got to go to the emergency room because we don't know.
Yes. Yeah, and people would delay because nobody wants to haul their kid in, and people are at work, their parents are at work and stuff like that. And so back then, whenever you would operate on these people with all these classic signs, 20% of them would turn out not to have appendicitis, and this was acceptable, and it was actually gold standard because we don't want to miss an appendix that's infected or inflamed or about to rupture. So you end up, because we didn't have imaging, we didn't have a way to ferret out these people.
Plus the risk of complications.
Complications, right? It was always big.
Peritonitis. Abscesses,
because you'd have to
operations.
Leave and you'd have to leave it open. In the old days, we would leave the wound open because of the pus whenever it pussed out. So very big, and eventually we were able to get it down to how much. Now we're pretty good with the CAT scans with adults.
Yeah,
and
between
stuff like that.
CAT scan and I would tell you that from my standpoint.
History and physical.
It's one of those things that by the time we're called, the CAT scans, the blood tests, everything's been done. The consents are signed, and as we just come in and practically do the surgery. Before, you'd look through all these types of things, you make sure. And again, we tend to see, especially in the younger children, some of the different people who have either birth defects or I guess you'd say mentally slow.
Yes.
Those are people you have to really take time because they may not be able to tell you things or communicate with you to where. So it really becomes a thing of judgment and saying, here's what it is. And I would tell you that when we operate on those patients and there's appendicitis, they're like Iron Men after that. Their pain is minimal. They're like your best buddy. You know what I'm saying? Because just got rid of that thing that they may not be able to communicate with you.
Yes. Yeah. Antibiotics instead of surgery for kids. I know they've talked about it for many years now, and
I think that's one of those things that part of it is there may be some room for that. But the issue is medical legally. If you think they've got appendicitis and you don't operate, it's considered below the standard of care. So, from my standpoint. You're better to operate and not have that standard of care issue because we can talk to her blue in the face about that. But somebody, and they're always going to decide for the plaintiff in the medical malpractice.
Sure. Yeah. So, whenever it comes to something as straight as if you could diagnose it, but you didn't act with surgery.
We didn't seek them out to tell them they need to come in at midnight to have their appendix out. See what I'm saying? So it protects you from that issue more than anything. And the complication rates in young people especially are quite minimal.
Without perforation. And certainly obesity makes it harder. All these surgeries, hernias, gallbladders, appendix, all these things, obesity makes it harder in terms of reaching the area of importance and sometimes healing, dehisceling of wounds and stuff like that.
Well, and I would tell you probably from a pediatric surgery standpoint, aside from the academics where they have pediatricians and pediatric surgery on call,
all the time,
we're the default. General surgery is the default for after 5 o'clock and before 8 o'clock in the morning. So we always wind up getting those. And no job too big, no job too small.
Too small.
So
15. You say 15 minutes for
20 minutes for
laparoscope with a laparoscope. If it's not perforated, there's no adhesion.
In a child, I would probably not even do because most of them are not obese.
Right.
And you can make literally a 3/4 inch incision, and it's right there.
Yep.
You can see it. You can
Get
pull
one
it
finger
up through that.
Get one finger in there to bring it
get
out.
an instrument out. You bring it out, and you tell it immediately that it's appendicitis. You take everything down,
Right.
and you got a 3/4 inch incision for an appendix, and with that little amount, there's less uncomfortable than you were before surgery. So Tylenol again.
Yeah.
And if there's rupture or something, you can still irrigate them out.
Right.
You can even use that incision to put a laparoscope in there with a double lumen laparoscope, so you can irrigate and evacuate if you think there's pus or things like that. So it's quite easily done.
Gotcha. As far as you know, nothing else. And these people, nothing else seems to trigger these things other than fecalitis, or you said 70%. Nothing else correlates it. No. Well, sometimes I've heard. Go ahead, please.
Well, in children, probably not a whole lot of other things unless there's some kind of birth defect or things like that.
Yeah.
Tumors are very unusual, but they do
I have
occur.
seen. Yeah, unfortunately, I've had a couple of appendiceal carcinomas, and it's one of them. I mean, so please talk about it, because usually incidental finding saves their life.
Well, there's two forms of things that we see. Number one is appendiceal carcinoid, which is a secreting tumor,
which
you can see.
So carcinoid is different than carcinoma for the rest of the people. So please go ahead.
Well, a carcinoid tumor is a tumor that secretes hormones and things like that. That can
Neuroendocrine
cause,
tumor.
Different types of symptoms depending upon what it's
What's
causing.
secreting? Right.
Most of them tend to be towards the tip of the appendix.
So the end of the appendix.
Not close up to where the colon is.
All right.
And at least if we look at them and we find that there's a carcinoid that is less than a centimeter in diameter and greater than 2 centimeters from the base of the cecum, unless you feel nodes or see nodes, something that's more worrisome, that should be a curative operation, if that's all there is. Now, you will need to do other testing and stuff to look at that, nuclear medicine scans, colonoscopy if they haven't had one.
Just to let people know, whenever you hear carcinoma, so adenocarcinoma or carcinomas is just a generic word for cancers, but carcinoid is a very specific type of cancer. That's not the typical stuff that you hear
Very
about whenever.
slow growing.
Yeah, very slow growing. They secrete hormones and different types, like Dr. Smith says, and they can do everything from rashes to diarrhea to sweats, hypertension, all sorts of different things, palpitations. Yeah, and so yes,
failure.
Yep. So there's a range of stuff, and so there's a very special type, and it happens to happen. It happens to occur. It can occur anywhere in the body, but typically within GI tract, and it happens to be hidden you couldn't usually find it on colonoscopy if you happen to have a colonoscopy, even if they look over the opening of the appendix.
Unless it's right. I mean, unless you see it coming out of the orifice, you don't.
You don't see it, and the only way that we get it to it is accidentally or incidentally whenever we do appendix surgeries, and they'll find it. The pathologist or the surgeon or the pathologist will cut it open and see it, and then call the docs, and then it's a whole different set of problems. And then adenocarcinoma is the other thing that will happen in there.
You can't see adenocarcinoma just because the colonic mucosa is the same. And
the classic
it's
colon cancer.
Less. I mean, most of them, the question becomes, is this a cecal cancer or is this appendiceal? And so that's why a lot of times because the operation for adenocarcinoma, even if it's just to the appendix, is a formal colon operation for cancer, which is a formal right colectomy with a lymph node and all that kind of stuff.
So what people don't realize is that even the cecum, which is what the appendix is attached to, the cecum is the beginning of the colon. The appendix is attached to that. It's actually the blood supply and the lymphatic drainage that determines the prognosis. And so people, even though they're literally 2 inches apart from each other, an inch and a half apart, there's a big difference in terms of prognosis whenever it comes to type adenocarcinoma or colon cancer or appendiceal cancer.
Well, with any carcinoma, whether it's lung or whatever, you need the lymph nodes to know, is it in a more advanced stage? Does it need chemotherapy? Are we
adjuvants and all
getting
that stuff?
into radiation and stuff like that for that kind of things? Specialized chemotherapy treatments, depending upon the plurality of the tumors and stuff like that. I guess biological treatments.
Biologicals now, yes,
starting to be a big thing as well.
Right, that's correct. So, and typically for when to go back to school, when to go back to work, what about lifting, sex, all that stuff like that?
I think from an adult standpoint, again, you could be talking, if it's not ruptured and you don't have other abscesses or things like that, that you can be back to work within 2 weeks or so. If you're in a non-lifting capacity, or you're somebody who works on a telephone, if you are the biggest thing is driving. So if you get in a situation where you have to slam on the brakes and you can't because of the discomfort, but you could be even a work from home thing 2 days afterwards if you're feeling up to it. I guess that's what they used to say. The pediatricians, or pediatric surgeons would say, that's the most enjoyable operation to do in the entire world, because you can take a kid that's 2 years old and take his appendix out, and he'll live to 90 years old.
That's right.
And you've cured him.
That's right.
That's the one thing that you can
never
say
have appendicitis again.
Cure.
Cure
Is what they used to call it. Dr. Raffensperger at Children's Hospital in Chicago.
That's funny. Well, super. Well, this is excellent. Thank you. Thanks, Michael. This is very common. This is a very common problem. A lot of people worry whenever they have belly discomforts or nausea or anything. It's like, is it more serious than just a passing bug? And this is certainly one of the things that does require people to show up into emergency rooms typically.
It's something that's very simple, and it's something, if you procrastinate, becomes very complicated and can result in multiple operations, potentially even total disability and stuff like that if you don't get after it.
So, and I'll just review, because Vanessa does a better job than I do, but for review. So for appendicitis, typically lack of appetite, loss of appetite. The idea is, if I put your favorite food in front of you, would you want? It's like, well, I'm not hungry right now. Well, if I put your favorite food, would you want it? No, I don't want it. Then that's a loss of appetite, as opposed to I'm not hungry because I just ate. Fever, and fever is defined typically as what is 100.5 orally, or what is it?
Right around. Yeah, I mean, most people are less than 100. So
most of our baseline typically, whenever we're not sick, is less than 100 degrees Fahrenheit orally.
And I mean, just the general malaise, typical symptoms of right lower quadrant pain.
Yep.
It could be a kidney stone. We didn't really talk about that.
That's correct.
But most of those people, the pain is a totally different type of pain.
Yes, it is.
And they cannot not lay down. They want
That's
to
right.
move, whereas
they
the
got the
appendix, they
issues.
don't want to move.
Right. So these people sometimes some generalized belly pain, but it finally focuses down to the right lower belly, where, like I said, whenever you're standing up, you bring your right hand up to your hip, your pelvis, and you go across towards your, and that's where it'll get you. These people will want to hold still. They'll feel terrible. So if they hold still, typically bent over or kind of balled up in a fetal position, they'll tend to feel better, a little bit better, because the peritoneum is inflamed, the lining of their abdomen is inflamed, and so as long as they don't move it, whereas opposed to kidney stones and gallbladder attacks and having babies, those are colicky, crampy things where you want to move around and squirm and pace and stuff like that. So so these people that's the time to haul them in. So people like Michael and can take care of them. Well, super. Thanks, Michael. I really appreciate it.
Well, thank you, Chuck.
Yeah, I appreciate it.
Enjoyable.
Thanks for donating your time and talking to our audience. We're out.
Hey, y'all. It's Vanessa again. If you would like to get involved with the podcast, we would love your feedback to our email address at notyourdocpod@gmail.com. As always, you can check us out on Spotify or YouTube, and our website, notyourdoc.com, is up and running with links to all episodes in Dr. Tadros' original Not Your Doc blog. We'll catch you next time.
This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.